Thank you very much, Dr. Koppler, and thanks to the staff at the Research Center at King Faisal Specialist Hospital for organizing this webinar and for inviting me. And I also wish to extend a warm welcome to all the audience joining us this evening to discuss the cardiovascular implications of COVID-19. This illness is also known as severe acute respiratory syndrome, or SARS-CoV-2, which is a direct reference to its predominant lung involvement. But as we know, it has far-reaching implications beyond the lungs, and the cardiovascular system is involved in multiple ways. So we're here to describe and discuss some of this intersection between COVID and the cardiovascular system. And we'll do that by reviewing some of the key knowledge regarding COVID-19 as it pertains to cardiovascular disease, and address the phenomenon of clustering of cardiac risk factors and the high burden of cardiac disease among COVID patients. We'll also address the controversy of using renin-angiotensin system inhibitors among COVID patients, and cover the cardiovascular manifestations and complications of COVID, as well as its impact on general cardiac management. So as we know, it's been just over half a year since the first known case of human transmission was traced to a wet market in the southeastern Chinese city of Wuhan. And the prevailing theory is that the host animal was a bat, which through an intermediary species resulted in human transmission due to physical proximity. The viral genome was sequenced on January 6 by Chinese scientists, and was found to be an RNA virus that belongs to the coronavirus family. Now, this family has been known since 1966, and Dr. June Almeida at the University of Toronto is credited with its discovery. The family includes many subtypes, and it was largely dismissed as an unimportant cause of a flu-like illness. Now, that changed in 2002 with the SARS-1 outbreak in China, which had a case fatality rate of 11%, and a decade later the MERS outbreak in Saudi Arabia that had a case fatality rate of 34%. By comparison, the case fatality rate of COVID-19 is around 4%. And that lower number is due to a variety of factors, including these unique characteristics of the virus and its transmission, but it's also partly due to the extensive testing and the higher caseload, because the case fatality rate is estimated by measuring the number of deaths as a proportion of the number of confirmed cases. And the caseload for COVID-19 is extremely high. The infection fatality rate for COVID is around 0.6%. And this metric differs from case fatality rate because it measures the number of deaths as a proportion of estimated infections as opposed to confirmed cases. And based on this metric, COVID is at least 10 times more lethal than the common flu that's caused by influenza. Now, most early data describing the natural history and epidemiology of COVID is based on single-center retrospective studies from China. And this pandemic has also brought the process of peer review under a lot of scrutiny due to the publication of many preprint, non-peer-reviewed papers online, and a couple of well-publicized retractions of papers from highly reputable journals, highlighting the difficulty in balancing expediency and urgency to putting information out and doing that in the most responsible way. Now, since the early reports on COVID, it's been recognized that the disease disproportionately affects the age group of 65 years and above with greater severity, and among that group, the burden of cardiac risk factors and cardiac disease is higher compared to the non-COVID counterparts, and we learn about that mostly from studies that use the case control methodology like the one we have up here. So in this study done in northern Italy, investigators compared COVID cases to age and gender matched controls who were registered in their health database but did not have the virus, and it showed that the prevalence of coronary artery disease was higher by 40% compared to their matched cohorts. And the prevalence of heart failure was also double that of controls without the virus. And another study from a New York-based healthcare system showed that amongst those who were tested for COVID, those who tested positive had a higher proportion of hypertension compared to those who tested negative. And these findings were again confirmed through a meta-analysis of several studies from China that also showed a higher prevalence of hypertension, cardiac disease, and diabetes among COVID patients when compared to their general population. Furthermore, the case fatality rates among these individual groups was higher, sometimes approaching double that of the case fatality rate for the overall population that was infected. The question is whether cardiac risk factors and cardiac disease are simply a marker of susceptibility to infection and worse outcomes, or whether these risk factors directly increase susceptibility to COVID and are responsible for worse outcomes. Now, it's probably a combination of both, since the presence of cardiac disease is associated with worse health overall status on one hand, and on the other hand, presence of cardiac disease leads to limited cardiac reserve, which is essential to counter the ravages of this infection. But another intriguing question is whether treatments commonly used in managing cardiac disorders could also predispose to worse outcomes, and in particular, ACE inhibitors and angiotensin receptor blockers, which are amongst the most common therapies for a number of cardiac conditions, including hypertension, heart failure, and coronary artery disease. And the basis for this speculation is the role of angiotensin converting enzyme isoform 2 or ACE2 in viral entry. This enzyme is highly expressed as a protein on membranes of alveolar cells, the heart, the kidneys, and many other tissues. And the coronaviruses, including COVID-19, use this protein to enter the cell through endocytosis, and viral replication upon cell entry downregulates ACE2. And the principal function of the ACE2 system is that it acts as a counterweight to ACE1. ACE1, simply known as ACE, is the well-known enzyme that produces angiotensin 2, which is a potent vasoconstrictor that also promotes sodium retention and fibrosis, and it's an essential physiologic response in states of shock and heart failure, but it also has some deleterious effects. ACE2 breaks down angiotensin 2 into byproducts that are vasodilatory and antifibrotic, and this pathway therefore is beneficial. And while viral replication of COVID downregulates ACE2, ACE inhibitors and angiotensin receptor blockers may upregulate ACE2. So ACE inhibitors and ARBs have also been shown to possibly protect against lung injury, as suggested by a meta-analysis which showed that patients with community-acquired pneumonia in a non-COVID setting who used these agents had lower odds of death, and this effect may in part have been due to the potentiation of the ACE2 system. So the question is, do RAS inhibitors, through increased expression of ACE2, also increase binding sites for COVID and increase susceptibility to infection, or are they in fact protective like they are in community-acquired pneumonia? To answer these questions and to quell the media frenzy on this issue, 3 papers were simultaneously published in the New England Journal of Medicine the first week of May 2020. All 3 studies were done in different populations, used different statistical methods, but arrived at similar conclusions. The first of these reports used a large database of about 170 hospitals across 3 continents and compared hospitalized patients with COVID who had an outcome of either death or discharge. The study found no increased risk of in-hospital death with use of RAS inhibitors. The study, however, was retracted as the database it used was previously unknown, and its very existence and veracity were called into question. Another report that originated from northern Italy, which was referred to earlier, investigators here used a case-control methodology and compared the outcomes of COVID patients with age and gender-matched non-COVID patients in their health database. And while the use of ACE inhibitors and ARBs was higher among COVID cases on unadjusted analysis, there was no difference after adjustment for multiple variables in terms of risk of infection and disease severity. A third study from the New York-based healthcare system compared those with hypertension to propensity-matched individuals without hypertension, both COVID positive and negative, and they also confirmed that RAS inhibitors did not confer a higher risk for testing positive or disease severity. A fourth study by the Cleveland Group reached a similar conclusion, although a secondary finding suggested a high risk of RAS inhibitors and disease severity, but this finding was an outlier. Therefore, several professional societies have published recommendations on this issue. Most are similar to the American Heart Association recommendations, which state that RAS inhibitors should be continued in COVID-positive patients, a view that is also endorsed by the Ministry of Health guidelines here in Saudi Arabia. There's also insufficient data to recommend using these agents prophylactically, and if there is apprehension about using ACE inhibitors and ARBs, a direct renin inhibitor such as L-ascarin can be used because it has no impact on ACE activity or its expression. In those that are highly symptomatic, however, withdrawal of RAS inhibitors may be indicated not because of specific effects on COVID natural history, but to preserve hemodynamics and renal function. And ideally, we need, in order to answer these questions, randomized clinical trials, but those are unlikely to be done. So we'll now review some of the cardiac manifestations and complications of COVID-19. Now, one of the overarching questions is whether COVID causes myocardial injury. And there are various methods to assess injury, including imaging with echocardiography, that informs us about wall motion and systolic function. However, echo is operator dependent and requires proximity to the patient, which is a particular limitation given the contagiousness of the virus. EKG can also detect myocardial injury and arrhythmias, but while EKG findings are specific, they lack sensitivity for myocardial injury. Biomarkers, on the other hand, are widely available and are easy to obtain, and amongst the biomarkers available for detecting myocardial injury, troponins have a particular advantage. And that's because they're available in every healthcare system and they're reproducible even with different assays and different cutoffs, since those cutoffs are well established. And the biggest advantage for troponins is that they're highly specific and sensitive for myocardial injury, with the caveat that troponins do not inform us about the cause of injury. Troponins therefore do not provide enough granularity with regards to etiology, but rather they offer a bird's eye view of the extent of the problem. Now, one of the first retrospective cohort studies describing the natural history of COVID was a highly cited paper in The Lancet. Investigators here reported that 17% of their patients had elevated troponin I, and that non-survivors had a higher proportion of patients with elevated troponins and other biomarkers, including D-dimer and IL-6. And when comparing troponin trends between survivors and non-survivors, marked troponin elevations were seen amongst non-survivors, as shown by the red graph, particularly with a characteristic increase after 2 weeks that was not seen among survivors. And this pattern of increase was also applicable to other biomarkers, including D-dimer, IL-6, LDH, and ferritin. Another study from China confirmed these findings, as 16% of their cohort had elevated troponins, and based on a cutoff of 0.026 for troponin I, any level above that was found to be predictive of worse survival, with roughly 2/3 of non-survivors, or 76% to be exact, having elevations in troponins compared to only 10% elevation amongst those who survived. Troponin was therefore predictive of poor prognosis, but elevations could also be seen among survivors, and it is not uniform to see troponin elevation amongst non-survivors. A pooled analysis of 26 studies, mostly from China, showed that myocardial injury occurred between 5 to 38% of the population, and the overall pooled estimate of myocardial injury was 20%. But what does troponin elevation mean in terms of the underlying cause? As pointed out earlier, biomarker elevations can be due to a variety of causes. Troponins increase in myocardial infarction due to plaque rupture, also known as type 1 MI, or due to supply-demand mismatch because of hypoxia, especially in those with underlying coronary artery disease, that is otherwise known as type 2 MI. Elevations are also seen in myocarditis, stress-induced cardiomyopathy, sepsis, RV strain from pulmonary embolism or due to stiff lungs, renal failure, and arrhythmias. What's important to recognize is that in COVID patient, more than one mechanism may be operative, and identifying the specific cause requires multiple investigations. And not only that level of testing is not uniform or standardized, but testing in general has been underutilized due to risk of infection. So epidemiologic studies, therefore, are not going to provide enough granularity regarding the prevalence of specific causes of myocardial injury, but case reports and case series do shed some light on possible mechanisms of myocardial injury in COVID patients. This, for example, is a case of a 61-year-old woman who had a history of coronary artery disease that was treated with multiple PCIs in the past. She presented with left-sided chest pain, shortness of breath, and cough. She was afebrile, and her electrocardiogram showed ST segment elevation in the inferior leads 2, 3, and AVF, as indicated by the red arrows. She also had ST segment depression in precordial leads V1 to V3, indicated by the blue arrows, representing reciprocal changes or posterior extension of her MI. Her chest X-ray showed pulmonary edema, and both troponin and NT-proBNP were elevated to support the diagnosis of heart failure. Given the diagnosis of acute inferior ST elevation MI, she was taken to the cath lab where coronary angiography showed a subtotal occlusion of her RCA stent. She therefore underwent aspiration thrombectomy and a drug-eluting stent implantation. Her ST segments normalized, indicating successful reperfusion. However, the changes on her X-ray persisted despite receiving diuretics, and she proceeded to requiring ventilation. By then, she also tested positive for COVID. Several similar reports have been published, and our anecdotal experience certainly reflects what's been in these reports. The question that arises is whether MI and COVID positivity is a mere coincidence in these cases, or whether COVID increases the risk of myocardial infarction. And that question merits consideration because it has previously been shown that flu due to influenza is associated with a 6-fold increased risk of MI, and that risk reaches 10-folds in those with influenza type B. This Ontario-based study showed less increased odds of MI with other viruses, including RSV and coronaviruses. However, there is insufficient data to inform us on whether COVID-19 increases the risk of MI. That said, the presentation of a patient with COVID and acute MI or heart failure can overlap with COVID symptoms, and an acute MI does not preclude the possibility of a patient being COVID positive. Investigators have also sought to explore the phenomenon of ST segment elevation among COVID patients, and in this case series of 18 patients in New York, all COVID positive patients with ST elevation were stratified after workup into those with underlying coronary artery disease and those without underlying coronary disease, presumably because of myocarditis and other phenomena. Some patterns may help distinguish between the two groups. For example, patients with coronary disease were more likely to present with chest pain as opposed to those without coronary disease. Both groups had troponin elevations, but absolute level was higher among those with coronary disease compared to those without coronary disease. All patients with coronary disease had focal ST elevation, whereas those with non-coronary ST elevation had both focal and diffuse ST elevation. So while focal ST elevation may require urgent cath, atypical patterns may be better served with CT coronary angiography, as they're unlikely to represent plaque rupture. And despite more biomarker elevation among those with coronary MI, ST elevation among non-coronary patients was almost always fatal, with 90% mortality, likely because it reflected diffuse myocardial injury from a severe phenotype of COVID and myocarditis. So it is obvious that myocardial injury from myocarditis is a serious problem, but its diagnosis is not always straightforward. The historical gold standard is endomyocardial biopsy, interpreted as by the Dallas criteria, which take into account presence of lymphocytic infiltrates and extent of myonecrosis. It is, however, an invasive test that suffers from modest specificity and poor sensitivity. The WHO criteria require additional testing for immunological markers. Furthermore, the indication for endomyocardial biopsy is not uniform across professional societies. For example, the American College of Cardiology recommends biopsy in case of fulminant myocarditis or insidious heart failure that doesn't respond to usual measures within 3 months. The European Society of Cardiology, on the other hand, recommends endomyocardial biopsy on all suspected cases of myocarditis. Such an approach is neither followed here nor is practical, especially during this pandemic. The diagnosis of myocarditis, therefore, is based on results of tests from different categories, including the category of clinical symptoms, objective evidence of cardiac dysfunction with exclusion of coronary ischemia, supportive MRI findings for myocardial edema or hyperemia, and endomyocardial biopsy. If test results from multiple categories support the diagnosis of myocarditis, the probability of myocarditis is higher. But given the lack of uniformity and standards for investigating myocarditis, case reports and case series can also suffer from methodological issues. Take the example of this claimed first case report of COVID-19 with fulminant myocarditis, where a patient is described with classic symptoms of COVID. He tests positive for COVID and has elevation in troponin and NT-proBNP, as well as global reduction in systolic function with increased wall thickness. This patient then goes on to requiring mechanical ventilation, hemodialysis, and ECMO. And after a few days, his ejection fraction normalizes with normalization of wall thickness. So even though the case findings are quite consistent with myocarditis, there was no coronary evaluation, although one might argue that is necessary given global LV dysfunction recovery, but there's also lack of cardiac MRI and biopsy. And while myocarditis is a likely explanation, especially given troponin elevation, there are several clinical confounders where stress-induced cardiomyopathy, sepsis, and uremia cannot be excluded as causes of cardiac dysfunction. Lack of tissue biopsy also deprives from important mechanistic information. In another case report of a patient with a clinical picture consistent with myocarditis, the investigators went further by demonstrating a normal coronary angiogram and a cardiac MRI which showed increased T2 signal consistent with diffuse myocardial edema. So even if a biopsy wasn't done, criteria from 3 categories were fulfilled for myocarditis. In another report, the investigators went even further. Because of an unusual pattern of wall motion abnormality characterized by basal hypokinesis, cardiac MR was pursued and it showed diffuse myocardial edema. The team performed endomyocardial biopsy which demonstrated a lymphocytic infiltrate and mild myonecrosis. Studies for viral genome showed no evidence of COVID in cardiac tissue. So has viral infiltration of myocardial tissue ever been demonstrated? In a report that is so far the only one of its kind, a COVID-positive patient with fulminant myocarditis was treated with ECMO, and endomyocardial biopsy and electron microscopy both showed the virus in macrophages. So while other case reports have detected viral genome in myocardial tissue, this is the only known report of actually visualizing the virus in the heart. What is notable is that the virus was not present in myocardial cells, but it was rather present inside the macrophages. So to conclude, characterization of myocarditis in the literature is incomplete. It has a variable clinical presentation that could overlap with other syndromes of myocardial injury and has a variable disease course with recovery a common outcome with good supportive care. Mechanistically, transient viremia through migratory macrophages rather than viral infiltration of myocardial tissue and cytokine-mediated hyperinflammatory host response appear to mediate myocarditis. Therefore, it appears that in patients with a mild form of disease, the host immune response counters viral replication. But in those with more severe disease, an unmitigated immune response overwhelms the host, causing multi-organ involvement including the heart. Cardiac injury and severe COVID could be due to immune-mediated myocarditis, but also because of hypoxia, plaque rupture, microthrombi, coronary vasospasm, and endotheliitis. Other than MI and myocarditis, acute cor pulmonale has been described in the presence and absence of pulmonary embolism. ARDS due to COVID may be difficult to differentiate from cardiogenic pulmonary edema, and that would require right heart catheterization. Arrhythmias are common and could occur from cardiac injury, metabolic derangements, and medication side effects. A rare syndrome of host-mediated hyperinflammation in children has also been described, sharing some parallels with childhood vasculitis. Drugs have also been implicated in cardiac toxicity. Now, with regards to drugs, several have been used in managing COVID and are currently approved by the Ministry of Health as per the date of this presentation. The first of these is hydroxychloroquine. It is still in the treatment algorithm for mild to moderate disease as per the MOH guidelines. It can prolong the QT interval in dose-dependent manner. It also inhibits cytochrome P450, and dose reduction in beta blockers may be required. It's also postulated to exert direct cardiac toxicity. The following 3 groups constitute what's known as triple therapy. and they include lopinavir, ritonavir, interferon, and ribavirin. These are indicated for the entire spectrum of COVID from mild to severe disease as first-line agents. The anti-HIV combination of lopinavir and ritonavir strongly inhibits CYP3A4, mandating dose reduction of apixaban, statins, antiarrhythmic, and tacrolimus. Several other drugs such as rivaroxaban, clopidogrel, and ticagrelor are contraindicated. QT prolongation can also occur, and dose reductions are required if corrected QT is more than 480 milliseconds. Interferon can cause direct myocardial toxicity and interfere with warfarin metabolism through unknown mechanism. Ribavirin can also interfere with warfarin metabolism and has the potential of causing both fatal and non-fatal MI. Remdesivir is approved for critical COVID cases. It is a potential inducer of CYP3A4, but there are no recommendations for managing its drug-to-drug interactions. Now, with regards to general cardiovascular disease management as it pertains to both COVID positive and negative patients, the question is how to manage acute myocardial infarction, especially ST elevation MI. The US recommendations from SKY strongly suggest the use of primary PCI as the default strategy, except at non-PCI facility, because the success rate for fibrinolytic is around 50%, so that could lead to higher rates of rescue PCI and subsequently a higher need for ICU care and ventilation. The use of primary PCI also allows the identification of STEMI mimickers, in which cases fibrinolytic therapy may cause undue harm. To the contrary to that, the Saudi counterpart of SKY, SASIS, divides STEMI into two groups, high risk and low risk. High risk STEMI are those involving the anterior wall due to LAD involvement, and their algorithm suggests that if the patient is COVID positive, even with an anterior MI, they should receive fibrinolytic therapy, or if the case is suspected to be COVID positive or they have a high COVID score, then fibrinolytic therapy should be instituted. The only situation where primary PCI could be given if the case is not suspected to be COVID and their COVID score is low. With regards to low-risk STEMI involving circumflex or the RCA, they recommend fibrinolytic therapy only regardless of the COVID status or the COVID score, and they recommend a quite conservative approach of deferring even rescue PCI in case fibrinolytic therapy fails. Though some general recommendations also apply, one needs to assume that all patients are COVID positive because there is insufficient time for testing, so personal protective equipment is needed, and negative pressure cath lab with the HEPA filter is also recommended. Atypical STEMI presentations should be considered. Patients presenting with atypical ECGs or equivocal symptoms could be first triaged with echocardiography, coronary CT angiography, or the cath lab. In cases of advanced COVID involvement, there might be futility of care, and PCI in those situations should be deferred. In cases of cardiogenic shock, consideration should be given to temporary support as opposed to implantation of durable assist devices, and one needs to consider early discharge in all of these situations to free up beds as soon as possible. With regards to non-ST elevation MI, most professional societies agree that these cases should be managed initially with medical therapy for up to 48 hours. The advantage of routine early catheterization is outweighed by the risks of COVID, but cath lab can be considered if the patient is hemodynamically unstable or they have a severe presentation of heart failure or life-threatening ventricular arrhythmias. A couple of other points to keep into consideration is to minimize staff, keep the door shut for the cath lab, and clean the lab 1 hour after the procedure to allow for the aerosolized particulate matter to settle down. This is a very useful scheme that is published in the SASIS recommendations, providing some guidelines on how to properly dress and undress when entering or exiting the cath lab. Now, with regards to recommendations for non-invasive testing, the American Society of Echocardiography suggests reviewing the indication for echo and take into consideration whether the test will alter management. They also suggest deferring all echoes if they are non-urgent, regardless of COVID status, and the service to be selectively provided for inpatients and some outpatients on a case-by-case basis. With regards to transesophageal echocardiography, aerosol level PPE precautions are required regardless of COVID status. With regards to stress testing, a recent document on the safe reintroduction of cardiovascular services published in JACC provides some guidelines that stress testing should be provided on a selective basis where management may be altered, and pharmacological testing is preferred over exercise testing. The same document also provides some guidance on which services should be reintroduced on ethical basis, on the principle of maximizing benefits and prioritizing procedures that provide greater benefit, like PCI, for a larger subset of the patients, as opposed to, for example, TAVR. Partnership with public health policymakers is required in these decisions, and cessation of most elective procedures is necessary if COVID admissions or fatalities increase. They also advocate PPE and COVID testing for all cardiovascular procedures whenever possible. So I will conclude here with a couple of remarks. The COVID-19 pandemic is a major public health test for healthcare recipients, providers, and the leadership. And as we have seen, the recommendations are mostly expert opinion-based, guided by limited data, regional trends of disease, partnership with policymakers, ethical considerations, and regional accountability standards. The cardiovascular disease presentation with COVID is quite variable, and that can sometimes lead to tailored and complex decision making. But the information we have overall is still evolving. It's a dynamic process, and we learn more and more about this disease, enigmatic disease, as time goes by. So one needs to stay tuned for further updates. And with that, I will conclude this presentation. I want to thank Dr. Coupler and the Research Center again, and want to thank our audience for their attention. Thank you very much.